This video continues Chapter 28 of OEC 6, looking at altitude-related emergencies. And in this video, we'll address some of these objectives. We'll talk about what altitude is and explain how oxygen changes as altitude increases. And we'll talk about signs and symptoms of these particular altitude illnesses. A couple of the terms that we'll encounter will be some of these particular altitude illnesses. We'll talk about acute mountain sickness, high altitude cerebral edema, and high altitude pulmonary edema. We'll relate these to the process of acclimatization. So altitude physiology begins with this idea. Our body has a unique ability to preserve homeostasis, which is a steady state. In chapter 25 and 26, we talk about the ability to thermoregulate, but we also have the ability to adapt to changes in altitude. Altitude is the height above mean sea level, which we call 0 feet, and altitude illnesses typically occur at higher than 8,000 feet above sea level. Now, in developing altitude illnesses, the rate of ascent is very important in determining the probability of that. If you ascend faster, it's more likely to cause problems. Even though the deadliest forms of altitude illness occur when you're higher above sea level, they can occur at intermediate altitudes as well, and there may be some genetic predisposition to susceptibility of altitude illness. Now, why does this occur? Because high altitude affects the amount of oxygen available to the body's cells. Low blood oxygen content is called hypoxemia, low oxygen in the blood. As altitude increases, really the oxygen remains at the same percentage. However, the partial pressure of the oxygen is much less. It's only about 69% of what it might be when you're at an altitude of 10,000 feet. And so that means diffusion of oxygen into the bloodstream through the fine vessels of the alveoli is going to occur much less ably. So severe medical consequences of ascending can be prevented through acclimatization, adjustment to that change in altitude, and that change in the uptake of oxygen. When less oxygen is available, the way that we do adapt is going to just prevent some of these altitude illnesses from occurring. If we know to expect it, how to avoid it and identify it, and what to do if symptoms arise, we can prepare ourselves for these challenging conditions. So what happens during acclimatization is we get these physiological adjustments. We'll have increased rate and depth of respiration because the partial pressure of oxygen is less. We can push more into the bloodstream by simply breathing more. Increased heart rate will help with that, perfusion as well, and increased red blood cell production simply to allow the oxygen to latch on to more of the carriers that we need to go to distal tissues. Pulmonary blood vessels will constrict and we'll see increased urine production as well. The ability to acclimatize really varies from person to person and may be unrelated to how physically fit they are. Some people adapt very quickly without discomfort. Other people will develop these altitude illnesses. The severity of altitude illness, once again, really depends on the rate of altitude ascent and the ultimate elevation attained. More important is the sleeping altitude. If you spend time at high altitudes, you may be less susceptible. Exertion can predispose you to some of these, and once again, there's some genetic components possible as well. Altitude-related problems begin with acute mountain sickness. So we get this rapid onset idea after moving to high altitudes. It can occur within several hours to 1 day after ascension to a high altitude. If your rate of ascent outpaces your body's ability to adjust, you're not going to maintain homeostasis. It typically occurs at altitudes greater than 8,000 feet and is going to be really prevalent, again, in people who rapidly ascend from elevations that are below 2,000 feet. AMS affects 25% of all the visitors who sleep above 8,000 feet in Colorado. Now, it's characterized by mild or moderate headache, along with some nausea and lack of appetite, and a general feeling of malaise. That headache develops within 2 to 12 hours. Many people really compare it to the feeling that you have from a hangover. and these symptoms will develop within 12 to 24 hours after arrival, but could happen even sooner, up to 4 to 6 hours after arrival if an individual is susceptible. The symptoms will decrease over time because the patient is going to acclimatize typically. Many times it can be misdiagnosed as a hangover or exhaustion or maybe some nondescript sort of a flu-like illness. But we need to be careful because it can progress. We get high altitude pulmonary edema. High altitude pulmonary edema is essentially a fluid buildup in the lungs, swelling in the lungs, just as we see in a cardiac pulmonary edema. Why? Because the heart's not pumping correctly. And we get excessive blood pressure in the pulmonary artery leading away from the heart to the lungs. That's going to allow some fluid to move across the capillaries in the alveoli and start to fill some of those alveoli. We get fluid buildup, pulmonary edema, but the cause this time, high altitude. HAPE is the most common cause of altitude-related death. It's not likely to occur below 8,000 feet, but it's the result of several factors. Once again, the ascent rate and the ultimate altitude that you reach. It can be physical exertions should be considered in the development of HAPE, and it's usually going to occur within the first 2 to 4 days of ascent to those higher altitudes. If it's untreated, the fatigue that the patient starts with is soon accompanied by lots of difficulty breathing, especially notably if the patient is exerting themselves. About half of the HAPE patients have symptoms of AMS first, but you can have onset of HAPE without AMS first in some cases. Now we'll see some of the hypoxia you can imagine from pulmonary edema with cyanosis in the nail beds and the lips. We'll see labored breathing at rest, and the edema piece is apparent in audible chest congestion. It can strike very quickly. If a patient has progressed to the point of pink frothy sputum, that's a very late finding. They're going to have profound hypoxia, and in this case it can become fatal within a few hours. Fortunately, patients respond very well if treated properly. High altitude cerebral edema is brain swelling. It's the most severe form of altitude illness. We might encounter it above about 9,600 feet. Again, it can be preceded by AMS, and about 3% of the patients who develop AMS can go on to develop high altitude cerebral edema. This is a true medical emergency. The progression of symptoms looks like this. One of the characteristics is ataxia, that lack of motor function. Sometimes we call those the umbles. We get altered mental status because of the cerebral edema. We get mumbles or difficulty speaking. We get ataxia. We get stumbling and loss of motor function. Hallucinations and psychotic behavior may be observed as well. Progression from AMS to HACE-induced coma can be as fast as 12 hours. But again, recovery can be quick if caught early, but we have to be mindful it can be very slow and result in long-term complications, including decreased brain or neurologic function. We're talking about swelling occurring in the brain, high-altitude cerebral edema. The final condition to consider is Kumbu cough or high-altitude bronchitis, inflammation of the bronchi. It's a dry, persistent cough that we find occurring in people who spend lots of time above 14,000 feet. That coughing can be pretty severe, can even break ribs, and it's named after the Khumbu region of Nepal near Mount Everest where it was first observed.